Hey, good afternoon, everyone. I'm Bushra Zaidi. I'm the second year fellow. So the topic of my today's presentation is addiction treated, hormones defeated. A dive into a Suboxone-linked adrenal insufficiency. That's one of the lesser known side effects of the medications. Nothing to disclose. So first, we'll talk about the learning objectives. First, we'll talk about how real-world clinical presentation can unveil hidden risk of buprenorphine, naloxone, Suboxone on the HPA axis. We'll recognize the clinical presentation and diagnostic workup of opioid-induced adrenal insufficiency. Then we'll summarize the talk with current literature that's available, linking Suboxone to the HPA axis suppression. And at the end, we'll discuss the management strategies and monitoring consideration for the patients who are on long-term medication-assisted treatment for opioid overuse. Starting with the clinical case, that's a real-world example that sparked the question when I was rotating back in VA. So the patient was a well-known patient to us even before this presentation, but we were seeing this patient for some other reason, for the reasons of Graves' disease, and then we were consulted mostly when the patient was admitted. The 38-year-old Caucasian male, history of polysubstance abuse disorder due to stimulants, opioids, sedatives, was on Suboxone for the opioid dependence, was on it for more than 5 years. At that point. Also has a history of psychiatric comorbidities, bipolar disorder, antisocial personality disorder, attention deficit hyperactivity disorder, and malingering. So this patient was had multiple admissions in the unit, in the psychiatric inpatient unit, and that's where we were a part of the care before this. Only this time, this patient presented with the usual suicidal ideation that the common presentation for this patient was, but then with that, he was having persistent nausea, vomiting, severe GI symptoms, generalized weakness, fatigue, and poor intake. The vitals on admission were a little low systolic 90, diastolic 54, was normal thermic, cool extremities, and was looking very dehydrated. That's when the patient was moved from the psychiatric inpatient to the medical inpatient. Initial labs showed potassium 4.4, sodium normal 138, creatinine was 0.67, glucose was 79 milligrams per deciliter. And that's all when we were consulted to see the patient, considering that maybe this is, again, the thyroid that's doing that. But I've got to mention here the thyroid profile at this time was normal. Looking at the symptoms of the patient, we checked the AM cortisol. It was low, it was 1.4. ACTH was sent, that was 10, that was reported later, but then slow. We did a cosintropin stimulation test, and that was done in the morning around 9:30 a.m. Baseline was 1.4 the same morning. 30 minutes was 6.7, that's still low. And then the 60 minutes was 11.3 microgram per deciliter. That was still low at the maximum response. Interpretation for this test was inappropriately low cortisol levels with suboptimal response to the dynamic testing. It was consistent with adrenal insufficiency. And the clinical turnaround for the patient, we started IV hydration. We started the patient on hydrocortisone 25 Q8 hourly, which was tapered later to physiological doses as the symptoms improved in the patient. And even we could see that day 1 and day 2, the patient had rapid clinical improvement in energy, GI symptoms, blood pressure stabilized, and patient was actually doing better. So we talk about bridging to the bigger picture. Is it a curious clinical clue or a missed medication risk that we're talking about? Despite no history of steroid withdrawal, normal thyroid labs, no recent infections, why did this patient develop adrenal insufficiency? No exogenous steroid use in the past, suboptimal adrenal response on our dynamic testing. But the patient was on long-term Suboxone. That's a combination of buprenorphine and naloxone. Could this medication itself be a missing link? This case opens the door to a lesser known but increasingly recognized adverse side effect, that's adrenal insufficiency caused by the Suboxone. We'll talk about opioid use in this section about public health crisis. Is Suboxone the final answer of that crisis? So a little background on opioid use and why we are talking about Suboxone and why its use is being increasingly being seen on all the reports that we see in NIH and all the other data cases that they have. Over 2.1 million people in US suffer from opioid use disorder. That's increasing every year. And more than 80,000 opioid-related overdose deaths occur annually, driven increasingly by synthetic opioids like fentanyl. And on the right side, you can see the graph that's only going up. And then that's the reason to cater to this, we something like Suboxone to say that these patients are not dying because of overdose. So Suboxone, when it was approved by FDA in 2002, it was like a magic drug, thinking of this probably will save the day. And then in 2006, it was linked to the medication-assisted treatment program by FDA, and it was approved for office use. MAT combined FDA approval medication with a behavioral therapy, and that's one of the ways that we make sure that patients are taking it in the way that they're supposed to take and not misusing it. And then we saw with the passing years from that to now, we saw the shifting practice from outpatient to inpatient initiation. There were studies show that inpatient initiation of Suboxone lowers the overdose risk and improves post-discharge treatment adherence. National guidelines for addiction medicine like ASAM, SAMHSA, that's also Addiction Medication Society, now endorse inpatient MAT initiation in patients which are admitted with overdose. So when we see the timeline, Suboxone use surged to 16.3 million prescriptions filled annually, with every 4.8 per 100 people on it. Policy changes like in 2021, 2023, there were initially some waivers required for a prescriber to prescribe this medication, but 2021 that was relaxed. By January 2023, that was totally eliminated, giving more payway to the physicians in any outpatient setting or inpatient setting to be able to provide the prescription for this medication. Prescriber growth followed, and then by December 2023, 53,600 clinicians were prescribing it, and there were like 11,500 prescriptions were going in 1 year. What's the pharmacological profile of this? Why we are talking about it? So it's a combination medication. What we are concerned today mostly is buprenorphine. That's a partial mu opioid receptor agonist, and that causes a ceiling effect on the neuroreceptor, preventing the withdrawal symptoms, also preventing the opioid to attach to it. Why naloxone is attached to that is because so that the person who's the medication is prescribed to cannot misuse the medication. So it's an antagonist. If somebody tries to just crush the tablet or tries to inject it intravenously, this naloxone is an antagonist. It will block the receptor, so the patient will immediately have the withdrawal symptoms, so they won't be able to use it. So that's like a safety net to this prescription. And this is just like a diagrammatic depiction of how this works. It's like a partial agonist. Even after 24 to 72 hours of the medication, when the effect is slightly weaning off, it still blocks the opioids and have this barrier for them to prevent any of the opioid to attach to that without any withdrawal symptoms. And now comes the question: Suboxone and the HPA axis, is it really safe? Is this the answer that we're looking for, or is it without any risk attached to that? To answer that question, we'll talk about the HPA axis first. What is the hypothalamic pituitary adrenal axis, and how is the Suboxone causing any effect on that? So we'll talk about brief review of the axis, how was the regulation, and how opioid use disorder and medication-assisted treatment fits into this picture. In this, so we'll just I could only find this picture, but just ignore the right side first. I will talk about the ignore the left side. We'll talk about the right side of the picture. So it's a hypothalamus, and then pituitary gland, and the adrenal glands. So what usually happens is that whenever we need a cortisol in the body, the hypothalamus produces the CRH, and then that's caused the pituitary gland to produce the ACTH that acts on the adrenal gland to cause the secretion of the cortisol in a short form. How the Suboxone and opioids affecting this is they suppress the hypothalamus and pituitary both. So CRH production as well as the CTH production is reduced. That leads to decreased adrenal hormone production, including cortisol and DHEAs. Not Suboxone, but other opioids also have effect on gonadotropins. In general, opioids will see the low testosterone, DHT, and estradiol secretions, but we don't have enough data for the Suboxone to comment on this for now. What is adrenal insufficiency? So it's, like I said, insufficient production of the cortisol with or without aldosterone deficiency. There are several types. We'll mainly focus on secondary and tertiary cause caused by this medication, but the primary is Addison's disease that usually is diagnosed early, and then that's because of the destruction of the gland. Mostly the one that's because of the medication is the tertiary, but in this case, we have effect on both tertiary and the secondary level of that. Now, symptoms are usually very, very generalized: fatigue, orthostatic hypotension, abdominal discomfort, electrolyte abnormalities. So the most common electrolyte abnormality that we see with these patients on presentation is hyponatremia. So whenever that is the case, always should have in the back of our mind that, we should look for this condition as well. There have had patients in our inpatient rotation who just presented with hyponatremia, and we checked, and then that was the only symptom or sign that the patient was having. It's just how opioid generally are linked to it, and what is FDA status on that. So initially, when the Suboxone was introduced, there was no safety net to that. There was no adverse effects mentioned. But in 2016, FDA posted a safety alert linking adrenal insufficiency to the risk as the opioid prescription all over. That also included Suboxone in it. And recently, there's an updated safety warning in 2023 mentioning specifically that Suboxone may cause this, and then what to do and how to treat that. So this is the 2016, which talks about how this again affects the adrenal gland, but that was like very generalized and then not very clear. But then 2023, they did acknowledge that if diagnosed, treat with physiological replacement of corticosteroids and wean patient off of opioids. That's the recommendation on the Suboxone prescription itself by FDA. And now we talk about how the buprenorphine as a partial mu opioid agonist is causing that linkage. So the mechanism is the same as opioids, and this is partial. So there is some connection to it. We don't have a lot of data talking about it. We only have like here and there small cohort studies, case studies talking about how the patients presented, or small cohort study looking at the data backwards to see if that's the association. So that's the reason clinical awareness is crucial to diagnose these patients timely and start the management. I'll come to the section 5 of my talk. That's the literature review. Like I said, we don't have like a lot of data on this topic. I'll start from the very, very back. What I found, this is the experimental foundation for this, how opioids and HPA axis are linked. So this is a study that was published in 2000. And this is talking about how animal models, how the animal studies were conducted on the animal models and what they found. Overall, this is like a very complicated study that they looked at a lot of things, but I'll just focus on the areas that are of interest to us. How they received the buprenorphine and how the effects were on the ACTH release or cortisol release on these patients. So again, it's an animal study design, evaluated acute administration of buprenorphine versus morphine in rats. They injected it at the periaqueductal gray area of the rat. That's the region with a high mu opioid receptor concentration. They measured the neuroendocrine and immune responses of the rats, including the ACTH and corticosterone levels for those. And why it matters is that the PAG is critical for opioid receptors, the modulation of pain and regulation of HPA axis, making it a valuable model if we want to connect those dots to our clinical scenarios of these days in human patients. Key findings for the study was that when they injected the morphine, it caused significantly increased ACTH and corticosterone production and acute HPA axis stimulation. That was there was known and then there was expected. But with the buprenorphine, they saw that this response was blunted, reduced ACTH and corticosteroid release. The interpretation for this was that buprenorphine, despite being a partial agonist, suppresses HPA axis activity more than morphine under specific central nervous conditions. And the clinical translation they had was chronic use may result in inadequate stress hormone response in these patients. How it's relevant to our case, from bench to our bedside patient. The animal model supports a central mechanism by which buprenorphine can inhibit ACTH in cortisol production, aligning with our patient's suppressed HPA axis. So in the study model with this animal and observed in our patient, both had low ACTH, low cortisol, blunted stress axis. So the patient had fatigue, hypotension, poor intake, even though he was admitted in this hospital admission with suicidal ideation, where the stress response was expected, but then he was not having any of that. HPA suppression without exogenous steroids, that was similar to our patient with no history of any steroids in the past. This is another patient, another paper that I found in 2015. Bushra et al. Their group published a few papers based on this data. This is like a opioid partial agonist buprenorphine dampens response to psychosocial stress in human. Their objective was to examine how buprenorphine, a partial mu agonist receptor, affects physiological and emotional response to psychosocial stress in a healthy adult. So this was a very small study where they recruited, it was a randomized double-blind placebo-controlled crossover trial. They recruited 48 healthy adults with no psychiatric, no endocrine, no substance use disorder history. They were on no regular medication, no hormonal contraceptive, and those patients were also told to not to take alcohol for the last 48 hours before coming into this study. They had a 7-hour period where they tested those individuals with, they divided blindly into 3 groups where they're getting a placebo of buprenorphine or 0.2 milligram of buprenorphine or a 0.4 milligram. Each subject tested under both conditions, separated by at least 1 week. How they checked for the stress. So in this study, they did not do a dynamic testing to find out if the cortisol response is suboptimal. They just checked the physiological stresses. So they did the trier social stress test. That's like a very well validated model for acute psychosocial stress response. So that was like a 5-minute public speaking and a 5-minute mental arithmetic exam solution in front of an evaluator. That was like a stress that was given to these patients, and then they were supposed to respond to these. So I forgot to mention here, so there was a placebo group that was given, so this was the stress group, and then there was the on controls with that. They had people just sitting in an empty, quiet room, and they were just asked to think of a nice book, write the name, or just play a game, like very, very normal things, very non-stress. So that group they labeled as non-stress. They collected a plasma ACTH cortisol levels baseline and multiple time points post-stress. Subjective ratings for anxiety, mood, stress via visual analog scales as well. They also monitored the heart rate and blood pressure. They administered both doses of buprenorphine or placebo, and 90 minutes after they started these testing, just to make sure that there's enough time for the absorption of the medication and the effects, if any. And they kept on checking the endocrine physiological responses up to 90 minutes post the stress test. So it was like a total of like 7-hour duration. The key findings were buprenorphine significantly blunted cortisol as well as ACTH's response to acute stress compared to placebo. So one of the diagram they put in there was this black part. The black bar is the normal one with the placebo, and they're doing this PSA scoring, and then this response keeps on blunting even in the control and even the stress ones on the doses. So their overall generalized the cortisol and ACTH response was blunted. And then there was another diagram. So this shows the effects of buprenorphine on cortisol responses to stress. So they just kept on, they plotted this graph based on how they measured the cortisol based on different time points after the dose was given. And like you can see that placebo, at the time the dose was given, their cortisol level rose up to after the stress was given, and then started coming down, which dampened both in 0.2 milligram dose as well as 0.4 milligram dose. What was the mechanism that they proposed was that buprenorphine activates central mu-opioid receptors, leading to suppression of CRH and ACTH. This results in attenuated cortisol release even during a high stress challenge. And they did see that in the placebo group, the ACTH was blunted, cortisol was blunted, anxiety was actually decreased. And then the takeaway was buprenorphine impairs normal HPA axis reactivity in the otherwise healthy individuals as well, because these were the group with no other medical problems, no other medical medication as a regular medical history. And they also talked about the subjective experience and physiological experience of those patients. So anxiety and distress ratings were lower with buprenorphine as expected. Participants reported less negative effect during and after stress exposure. Physiological effects, so no significant difference in the heart rate or blood pressure, effect specific to HPA axis suppression, not general autonomic dampening. And that's very important, that if blood pressure is low in a person and then we're checking the cortisol levels and the cortisol levels are okay. So, I mean, we can't blame all the low blood pressure to adrenal axis. It's just on patients on Suboxone, according to their study, the HPA axis suppression was the only thing in the affected in the physiological. The general autonomic dampening was not observed in these patients. That brings me to the section 6, clinical presentation and adrenal recovery. So again, like in our patient, the clinical presentation of these patients is very, very, very generalized. They can present with any and whatever signs or symptoms. Presentation can be anywhere from GI bleed, septic shock, or just headache, fatigue, hypotension, anything. So that's very important to pay attention to whenever we are evaluating a patient, even one of the signs that we see. I included this study so it's a busy slide, so I'll just take it apart. I included this because of the reason that they talk about what are the different clinical presentations of these patients. One of the lacking point in this study is that Suboxone use, so they gathered all the opioid induced adrenal insufficiency diagnosis from a Mayo clinic, but then when they cut it down, Suboxone was only in 2.5% of the patients were using Suboxone. Others were using like fentanyl or other prescriptions that was causing the adrenal insufficiency. In relation to our topic specifically today, Suboxone was only 2.5%, but then we can still talk about it in terms of how these patients present clinically. It was a single center retrospective cohort study. They had adult patients more than 18 years, opioid use more than 90 years. Those patients were already diagnosed with opioid-induced adrenal insufficiency and were already started on the glucocorticoid therapy. They excluded anybody with a known HPA axis disorder, any recent steroid use, any severe liver or renal disease, or any cancer-related pain, because those patients are already on a high dose opioids. And then diagnosis was via clinical and biochemical endocrine evaluation. Again, we are talking about retrospective, so it was all chart-based data. Outcomes were resolution of adrenal insufficiency. So in some of the patients, there was like a discontinuation of the therapy, and post-discontinuation, they documented normal adrenal labs and no new symptoms after that. And symptom improvement was based on follow-up notes in the clinics, in the Mayo Clinic endocrine outpatient department. They did, all the patients that were included in the study had a dynamic testing done, and then they had a 250 microgram concentropin over 30 seconds via anticubital, and then they collected baseline 30 minutes, 60 minutes, and they checked the peak cortisol level to assess the highest value among post-injection sample. Results, like I said, only one patient was on buprenorphine, but then we get to know about the clinical presentation of these patients. So this slide here talks about what were the most common presentations. So even if you go down this list, these are very generalized symptoms: fatigue, musculoskeletal pain, weight loss, headache, abdominal pain, nausea, anorexia, lightheadedness, vomiting, diarrhea, night sweats, syncope. So even if one of these symptoms there, and then no general physician would probably think about adrenal insufficiency as a part of their initial provisional diagnosis. But then these were they saw that the fatigue and musculoskeletal pain were the most common. And then if you can, I don't know if it's visible there, but if you can see that the gray area right here is the area that actually improves. So these symptoms improved after initiation of the steroid therapy in these patients. But then there were other factors like, I don't know how true this is, because whatever the patients we had, like vomiting, nausea, diarrhea, those symptoms improved in those patients. But then in this study, there was no improvement. So this is also very common. Delayed diagnosis was common based on these this data suggested symptoms of for a median of 12 months before it was diagnosed in one way or the other. Glucocorticoid therapy led to improvement. Like I said, 70% of the patients had symptom relief. And then we can talk about adrenal excess recovery in these patients. So based on this data, among those who stopped opioids, 70% regained normal adrenal function, which highlights the need to address both adrenal insufficiency as well as whether to continue the Suboxone or what to do with that. And I'm not saying that, we can't continue. It's an important medication. It's, of course, saving life for a lot of other patients who need it. But then, again, patient-based thinking on which patient actually needs it to continue. About the resolution, how long does it takes? So based on this data, median time to recovery after opioid cessation was 5 months, ranging from 1 to 13 months. There are other case reports talking about earlier resolution, 1 week to 3 months after Suboxone was discontinued. There was I couldn't find the actual abstract for this, like a version to be put on the screen, but there was an endocrine abstract in 2018 by Surfaraz et al. They talked about a case which patient had adrenal insufficiency and it was on a buprenorphine patch. They stopped the patch, cortisol levels normalized. For some reason, patients restarted the patch and then the cortisol level again got low, and then patient presented with the, so in that case report, they showed that the causation of that. And I'm going to talk about the extreme clinical presentations here. So like I said in the start, the presentation can be anything. So there was a case report I found about a patient who presented a septic shock, and adrenal crisis was actually masked by septic shock at the presentation. So this patient, patient presented in shock. They started all the shock management. They started the steroids and everything. When there was a time to wean the steroids off, they were not able to. And at that time, when the excess was checked after like normalizing the doses to a physiological doses and holding the dose, they saw that he had a suboptimal response and had actually a adrenal insufficiency, and the patient was on long-term Suboxone therapy. And again, I think this next one is actually one of ours. Clayton M. Smith, I think. So they also talked about, so this is a more recent one in 2024. So they talked about a patient who presented with GI bleed and some GI symptoms. After stabilizing to that, patient also was on Suboxone. They checked for HPA excess, and they saw that it was not optimal response, and the patient was diagnosed with opioid-induced adrenal insufficiency, was started on physiological doses and was feeling better after that. And like I said, presentation can be any, but if you have like a slightest back in your mind, slightest thought that if that's that, then it's a better idea to just check the AM cortisol. And that brings me to the last section of my talk, that's the management and monitoring clinical implications. In this section, we'll talk about the treatment of adrenal insufficiency, what to taper, risk-benefit assessment of continuing Suboxone, guidelines, if any, for screening or monitoring, and counseling patients and raising awareness among providers. So risk-benefits assessment of continuing Suboxone. Suboxone remains a first-line MET for opioid use disorder due to lower misuse potential. Adrenal insufficiency risk is rare but serious. Symptomatic patients need thorough endocrine evaluation. Shared decision-making is essential. Weigh addiction control versus endocrine health. If continued, ensure close endocrine follow-up. So new guidelines as of May, as of this month, we don't have like major society guidelines talking about this. Endocrine Society, A Society. There's no updated specific part talking about Suboxone-induced adrenal insufficiency, but then there was a paper by Adler et al. Talking about opioid endocrinopathy that was like 10 years old that did talk about some of the hormonal effect of this medication. We are still, we do have recent updates focusing on opioid tapering and non-hormonal management. But then we don't have any specific guidelines talking about, and that's why this talk is important today, that we need to, if you guys find any patient that you think was on Suboxone and adrenal insufficiency is diagnosed, we need to especially write them off so that, if it's much reported, they maybe consider starting some guidelines for that. Like I said, whatever data I included are some case reports, very small cohort studies that we have, and then some animal models in the back, which continue to raise concerns about buprenorphine's adrenal effect, but no guideline level change yet. And that brings me to strategic take-home message, why this matters. So opioid-induced adrenal suppression is underdiagnosed and often mistaken for fatigue, psychiatric relapse. Buprenorphine naloxone combination, Suboxone, despite being a partial agonist, can suppress the HPA axis, especially with long-term use. Patients with opioid use disorder deserve nuanced care, balancing addiction medication and endocrine health. And that's important for these patients because we cannot bluntly say that, stop the medication. And then, like I said, there's no guidelines yet, or even case reports pointing to that the Suboxone was stopped after that adrenal insufficiency was diagnosed and the patient did better. Most of the patients were started back on the treatment because of what they were going through in their addiction management profile. So it's important how to collaborate with these teams and then talk about for our intervention that's collaborative. And what should we do? So keep adrenal insufficiency in our differentials in patients on chronic MAT presenting with fatigue, hypotension, or hyponatremia. Like I said, that was the most common electrolyte abnormality which we saw. Advocate for cortisol testing when clinical suspicion arises. And again, it's like a 8 a.m. morning sample, not 4 a.m., not 5 a.m., not 10 a.m. 8 a.m. is the best one that we have based on the data, especially if we are deciding these things on the basis of that 8 a.m. cortisol level. Collaborate with addiction specialists or like psychiatry teams, internal medicine teams for integrated care, because though these patients usually present to their inpatient or outpatient clinics, and then that's why probably sometimes are missed. I will also talk about the future questions that brings this talk is like, what about, so in a generalized adrenal insufficiency, when we see that, we talk to those patients about sick day rules, about injection, crisis medication management, like a steroid injection for once use if you need to be. Do we do that with these patients? We don't know the answer to that. We are still we have like a few patients that we started these steroid therapy. And we haven't stopped it yet, and we don't know if those patients ever would be managed similarly. But I think based on the data that we have for adrenal insufficiency, at least the guidance to the patient would be the same. The sick day rule would be the same because these patients are dependent on the steroids. Crisis medication, based on what our observation based on the adrenal insufficiency overall would be the same as crisis management for the others. But there's no data backing that up yet. And with that, I'll just like to acknowledge Dr. Krishnasamy for helping me with all that, Dr. Burton, Dr. Kingery for all the help with their cases. And now you guys can ask any questions or any comments.
Hi, Dr. Zaidi. This is Dr. Burton at the VA. Can you hear me?
Yes, Dr. Burton, I can.
Great. So first of all, congratulations on your upcoming graduation from your fellowship. That's fantastic. Thank you for an excellent presentation. Not only was it thorough and comprehensive, but I think it's clinically relevant and it's helpful and makes us think. I want to say thank you to yourself and the endocrinology team, Dr. Krishna Swami. You guys have always provided excellent consultation service here to us at the psychiatry service at the VA, and we enjoy our collaborative relationship that we've had with you. This was certainly an interesting case, and you guys helped us a lot in understanding how to provide good care for this veteran. So, it's hard to know what to do. These are difficult, challenging situations. Patients are on Suboxone, obviously, for a chronic addiction disorder, and then developing a subsequent serious medical problem. You wonder, and you've alluded to this being under-recognized, I wonder if there would be thought to doing something like a study where we checked cortisol levels in patients who were in Suboxone treatment clinics or in methadone treatment clinics to compare those to controls to see if maybe there's more cases than we know about or recognize. Just a thought. And thank you again.
Well, a very nice question and a very, very good question. I think when I presented this case as a poster, one of the person who came to I'm just banking on the name, he came to me and then he said that he worked in a clinic that was prescribing Suboxone for 10 years. And then they never thought about it. And then the patients are actually having these symptoms. And then this is an interesting question. And then he said the same thing, that should we start checking this as a regular in patients, maybe more than 5 years Suboxone, just let's start taking like some guidelines for that. But I think it's a good idea. But then, like I said, there's no data yet, but we can definitely but then will we be overdoing it? Because there are like a lot of patients on Suboxone, but then how many of those actually develop that adrenal insufficiency? So I think what I think is based on symptoms, but I don't know if Dr. Krishnasamy has anything to.
Dr. Burton, that's a great question. Thank you. I think it needs to be done as a controlled study because just like Bushra said, not everybody who's on Suboxone has the symptoms. And of course, patients who are on chronic opioids, that's why they get the Suboxone, have very classic symptoms of fatigue, low energy, nausea, some of those symptoms, and of course, hypogonadism, that's a big issue, especially at the VA with methadone. So we haven't, there's a lot to look at here, but I think there are more questions than answers that we have, but certainly it's something we should discuss and talk about collaboratively as a group, perhaps to look into it. Thank you.
Thank you.
Yes, Dr. Kingery, go ahead.
One is, I agree, even a cross-sectional study is clearly needed. But I wonder about the theory of chronic Suboxone leads to higher prevalence of disease. Because the study that was done showed that even in 5 minutes of stressing someone out and giving them Suboxone, you can see a change, right?
I agree. Yeah.
So I don't know, maybe you get more prevalence later, but I'm not sure that prevalence wouldn't be very high day one. Right. Yeah. So if you do the cross-sectional study, I would suggest, you're saying more than 5 years. I'd probably do like on a week, on a day, and see, do a graduated response. You may see that you have the same prevalence across the board. The other thing I could think of is, in medicine, we see a lot of people in the NICU, and I'm sure you've seen some there as well, that are on fentanyl drips, right? And if opiates are causing this response within 5 minutes of us giving speech or whatever that study showed, is it possible that some of the people who are hard to wean off pressors in the NICU are because of the adrenal response to the fentanyl drips that they're on? And so that might be another patient population to think about.
Yeah, that's a very interesting thought. Thank you. Dr. Levinson, you had a question.
Well, I guess the prevalence is unknown.
Yes.
But is there any slight estimate of what it might be? Because if it's a small number, then I just kind of wonder why would it happen to those people, not to the others. I mean, it may just be individual abilities of the gland. But
I think so. A good question. So I think studies are needed because when we started, when we had this case, the next month I was inpatient and we had 3 more cases. It was because we knew what we were looking for and we saw those, and then so that's the case series that I have now. So to answer to your question, we don't know yet, but then that can be a very good project for resident level, or one of the fellows can.
Is it possible it has nothing to do with Suboxone? That the reason the people you see it in with on Suboxone are because those people were more susceptible to feeling bad when they were on the opiates and they tried to get off of them because they were getting the adrenal suppression from the opiate itself, and so that's why they came to get Suboxone.
So the 3 patients that I have, 2 of them I am sure. So one is this. 2 of them I'm sure that one of them was in prison for 25 years, and then one on So. Yeah, there was a slide I removed comparing the methadone and that.
It's just that the Suboxone, they're on for such a long, and methanol also, they're on, for such a long period of time. And it seems to take a while. Because you were saying if it happens to me, I thought it takes a while.
But that study shows that if
One
you
of
give it
the-
to people, even the control group.
Yeah.
The
But
earlier
then-
study, the human study showed that.
So
Very
one of the case reports that I had was that the female was on patch for 3 months. So that's not that big period. It's not years, it's months. So again, it can be variable. We don't know who, and then probably it would be interesting to find the mechanism. Is there something that's causing some to respond to this way, or some are not just responding and are on 20 years of Suboxone therapy with nothing.
Also, a word of caution, I think it'll be really great if you design that study to ask the question of how long they were on other opiates before the Suboxone.
Yes.
Yeah.
Someone's going to ask that.
Yes.
Yeah, absolutely. Pre and post sort of things.
'Cause it would be great if that didn't matter, right?
Yeah.
Because we had a patient, I know the CF team members are also on board here. We had a patient in the cystic fibrosis clinic who's on Megace for appetite, which also lowers your cortisol, and on Suboxone, both. So it's hard to say what is triggering what, and it's a very complicated. And the patient that we had with Dr. Burton, some of them are on street drugs, like the big billboard when you drive off on 71. So, and you don't know what is mixed in it, what is stimulating, what is suppressing. So it's a very complicated story there.
Now, your argument against me saying maybe it's not the Suboxone at all, it's just the opiates before, is that one case was really great where the person took off the patch or something and then put it back on.
So causation was. And then to answer to your previous question about the fentanyl, so one of the cases that I had was for septic shock. So they waited for the patient to stabilize, moved out of the ICU unit, and then the steroid drips were tapered off. They were on physiological levels for a couple of weeks of fentanyl. So I don't know. I think by that time, probably the fentanyl effect or that high dose steroid effect would be tapered off by a few weeks. So that's the only case that I have that I can comment on. So like I said, not a lot of data. We can
It's
just.
possible that we're making some of the people come in with drug overdose and we put them on pressors in the NICU and we get them fentanyl to sedate them.
Sedate them.
So we're making them worse.
Yes. Actually, I had an intention to email the ICU team also, but I got so busy that I didn't get a chance to do that. So yeah. Monica, you have a question? So the question is, should we rule out primary before we sort of conclude that it's secondary or tertiary?
So the Addison's disease would present differently, and then those patients they present early, and then they probably won't be on these medications. So when you take a history of the patient, that would probably guide you where you're leading to. And based on that, we're going to do the M-cortisol and ACTH level and all those. So those labs will tell us that what we're looking for. So not from inpatient. So what we usually do is when we get a consult and we see adrenal insufficiency, we start them on steroids because that's a longer workup, and that's usually done outpatient. So after even these patients, when we start them on steroids, we taper them to physiological doses, and then they are followed by endocrine outpatient. There we do the actual testing. And like I said, ACTH is it's sent from inside the hospital initially, but then it's usually resulted late. So we see that level when the patient is coming to us outpatient to see what the level was and then to comment. But then based on the
Basic-
history, we can point to if the patient is not having this probably the diagnosis.
I just remember.
That's more with the primary adrenal
primary.
insufficiency. But
Yeah.
typically these presentations are so different. It's similar to the patients who are on chronic epidural injections and you do or take steroids for something else and you do a cortisol level, it's 0.2 or 1, and they just had epidural yesterday. So it's almost similar to that versus the Addisons, they are hyperpigmented, they're very classic hyperkalemic, aldo is low also, and then the ACTH levels are sky high usually. So
I have one more question. Are there any theories on the molecular mechanism of this? Because it doesn't rationally make sense to me. Because in my head, I'm thinking these things are in the same very gray area, whatever it was, right?
Yeah.
Opiate receptor and steroid
Yeah.
suppression. or whatever.
Yeah.
But it seems to me that let's say I get a very painful response. I have endogenous opiates that bind to those things. That would be the exact same time I would want a high cortisol response.
Yeah.
So why do they cancel each other? It doesn't make sense to me.
So the only paper they have is very complicated paper. They talked about a lot of things, but then those a lot of things were like other responses, not about a molecular level why they were like measuring other things like epinephrine or all those things to see what the response to that. But then they didn't talk about like what's the only theory is that this is a partial agonist, but then chronic use in that area would cause this effect.
it's very interesting
Yeah.
because like you said, the acute dose versus frequent doses, how does it mute the receptor?
Acute dose in the study
Yeah.
lowered
Yeah.
the cortisol, but to me, an acute dose would be the perfect time you would want the cortisol.
Want the
Yeah.
cortisol,
Yeah.
yes, yeah. So
There's another case series that I didn't write here that's comprised of I think 2 cases that's recently published. But that was also talking about the same inpatient admissions with hypertension, inpatient admission with dizziness, and both were on Suboxone. One was 4 years, one was 1.5 year, and both were diagnosed. But then, like I said, it's only like scattered case reports that are published yet. We don't have like actual, even the cohort, there's only 1 or 2, I think. One is Adler, and then the other is the Bushra et al. Then we have, and the Mayo Clinic from 2020. After that, we don't have anything.
I mean, this is beautiful because number one, it is multiple services of medicine, right? Endocrine, psych, medicine, all having to work together to figure this out. That's
Yeah.
amazing. Too often we don't do that. Number two, there's going to be a molecular mechanism that someone
Definitely,
will be
yes.
figured out.
Yes.
And number two, it's probably a public health crisis that we don't know.
huge.
Yeah.
I mean, young
Amazing.
people.
And like we saw the graph in one of the slides, the fentanyl is like going up and up in every year. And that was from 2022. I didn't find anything from last 3 years. So
Yeah, it certainly is an important area. And the opioid related mechanism, I remember 10 years ago when I looked into it for a study, and when we went back and looked now, what I had 10 years ago,
Nothing.
there's not much new. And I
It's
was
just a case
surprised
report.
because I shared those slides. I'm like, wait a minute, after Adler's, discussion,
yeah.
there's not much. And this is like the elephant in the room, it's a huge crisis.
It's great. I love it.
Every-
You gave me a shout out. All I did was say, I think cortisol is low, and then I didn't know I didn't want to do stuff.
But if you didn't call us, we wouldn't know. Yeah, thank you, everybody. Thank you all for joining us today.